Hi, everyone. It's 1 o'clock, so we'll go ahead and get started. I just wanted to introduce myself quickly. My name is Nellie Sabor, and I'd like to welcome you to the Autism Intervention Research Network on Physical Health, the AARP October 2023 webinar on IDD curricula in the health professions, current state and future directions. So thank you all for joining us today. Because of the number of participants, your audio will be muted throughout the call. However, you can submit questions at any point during the presentation via the Q&A feature or in the chat box on the webinar console. Just a friendly reminder to please be respectful when communicating in the chat and asking questions, and note that only questions or comments pertaining to the presentation will be addressed. The entire webinar is going to be recorded and will be available on the AARP website, which we will put in the chat. You may also view the presenter slides to follow the presentation on your own in our Google Drive, which will also, the link will be put in the chat. There will be a short evaluation survey at the close of the webinar. We invite you to provide feedback on the webinar and also provide any suggestions for any future webinars. So in the interest of time, we'll go ahead and get started. Next slide, please. Thank you. We first want to acknowledge the Health Resources and Services Administration as the funding source for the AARP. Next slide, please. So now it is my honor to introduce our presenters for today, Dr. Keisha Rosana and Dr. Priya Chandan. Dr. Keisha Rosana is a developmental psychologist and an assistant professor in the Department of Medicine at UCLA. She's also the training director for the Leadership Education and Neurodevelopmental and Related Disabilities, UC-LEN program, and the clinical director for the UC-LEN clinic. Her work focuses on cognitive behavioral therapy for gender diverse, neurodivergent adults and increasing access to knowledgeable providers. And the next slide, please. Dr. Priya Chandan is a physician scientist who engages in health services research to improve the quality of medical care for people with disabilities. She's been involved in health policy and advocacy efforts for over 15 years and has served in leadership positions in both academia and industry at national, state, and local levels. She's currently a clinical associate professor at the University of Louisville School of Medicine and is passionate about medical education. So without further ado, I will hand it off to both of you.
Thank you, Nellie. Okay, so a little bit of an overview as to what Priya and I will be talking about today. We do want to make this as conversational as possible. So if you all have questions at any point in time, we are a friendly bunch. Please feel free to ask questions at any point. We would love to hear from all of you. Our plan of what we're going to cover today related to medical and dental school disability curriculum. First, we're going to talk a little bit about a recent survey that was conducted and some of the preliminary findings from the focus group. We'll also talk about this increased interest in disability-related curriculum over time. And then I'll turn it over to Priya to talk more about successful curriculum implementation. And then we also have some action items, some upcoming opportunities and ways that you all could get involved. So to start, the survey and focus group findings. There was a mixed method study that was funded by the WITH Foundation. The WITH Foundation funds some very cool work that is very inclusive in nature and really highlights self-advocates at the forefront of research and clinical work. So this mixed method study was a collaboration with UCLA, myself at UCLA, and then also AUCD. And what the goal was to examine the development and implementation of inclusive intellectual and developmental disabilities curriculum at medical and dental schools. We already know that most medical students feel that it is important for them to understand the treatment of individuals with disability and chronic illness populations. However, unfortunately, the majority of those students do not feel competent enough at treating patients with IDD and other disabilities. So it's really important that we gather more information about the existing efforts that are out there, especially to improve preclinical education as it surrounds disability. So in order to do that, as a first step, we created a survey tool, and we used a research advisory committee comprised majoritatively of people with IDD, as well as professionals in the field, family members of people with IDD, and others who all edited multiple versions of both the survey instrument, and then also what we eventually used as our focus group guide. This was titled as an advisory committee, but it was much more of an iterative process, and really a mixture of professional and lived experience. So it's probably a little bit closer to what's called a collaborative inclusion approach. And what we found in the end from this mixed method survey, we had 36 items, and we ended up with at least 62 participants as of the time that we pulled this data. From that, we saw some kind of interesting things. When we were asking specifically about the stages in the curriculum development process that self-advocates were involved, I was pleasantly surprised with some of the responses, and seeing how much self-advocates had been involved in the process. But one of the things that we wanted to understand with this study was understanding the ways in which they were meaningfully involved and the experiences of those self-advocates that were involved in the process. So it was quite a variety of different areas, right? That they were involved, from goal setting to evaluation, and that the majority were involved in more curriculum delivery and kind of the teaching process, as facilitators, panelists, and also lecturers. And I pulled a couple of quotes that I wanted to briefly touch on. We really saw variety in the responses, especially when it comes to meaningful inclusion of self-advocates in the curriculum development process. So some of them varied from all of my suggestions were implemented and I really felt listened to unfortunately some, commented that the individuals that they were working with were kind of rude, and it made them feel like their suggestions were less valued. One of the quotes that I really wanted to highlight that was striking to me when I first read it was when asked about kind of motivations for participating and trying to help support medical and dental school curriculum. One of the respondents said, "I just want people to know about what we go through." And I felt like that was really powerful, and something that I really wanted to highlight from the study. The individuals that were a part of these focus groups some of them were individuals who were active in their universities. They could be faculty and other, directors of different institutions within the university, and others were individuals from the community who had been involved in different ways. But universally, there seemed to be this message of really wanting to try to make a difference for the systems that exist, and also especially for future patients. Another thing that we found from the study was when we were trying to understand more about kind of perceived change in interest in more inclusive curriculum and how that looks across different institutions. And there definitely has been, an increase by lay media in the focus on ableism and awareness of disability, which could partially be from, the discrimination faced by this population during COVID. But I liked this quote that it said, "due to the work of disability advocates," because I think that acknowledging the immense amount of work that's being done by advocates and self-advocates in this area is really important. When we were looking at the interest kind of change over time, when we asked students, faculty, and administrators separately kind of where they thought that this interest was coming in from the most, The biggest increase we saw was within students. I don't know about others. This wasn't necessarily surprising to me. You know, when I'm meeting with patients and especially if I'm talking with parents and they may be concerned about bullying or concerned about, you know, friends understanding, you know, neurodevelopmental and related diagnoses. I'm happy to say that from my perception, it seems that in general, the younger generations are better than us in maybe quite a few ways, but especially when it comes to acceptance and being able to have kind of more open conversations around more equity issues, such as things with disability. So I thought that that was, you know, promising to see. It's also been promising that we found of the group that we surveyed, at least 46% had included self-advocates in the process in what they identified as a meaningful way. And so really trying to understand more about the experiences of the self-advocates. I think one of the big goals now that we've analyzed the majority of the data is identifying areas where there were strengths in how self-advocates were included within the curriculum development process, and then also some of these areas for growth. We want to be able to, you know, in the final report, talk about some of these strengths and give suggestions for other institutions who are trying to adopt a more inclusive disability curriculum and ways that self-advocates can be meaningfully included, while also cautioning or giving some more support and maybe tips in areas to not make the same mistakes that others have, and including individuals in, you know, in really meaningful ways, but also being more generally conscious. Unfortunately, one of the participants had commented during the survey creation process that they came in to give a talk as part of this curriculum delivery, and the room wasn't wheelchair accessible for them to enter the room to give their talk about, you know, being more mindful and having more neurodiversity oriented care within the medical field. So I think that that's very telling that there is a lot of work to be done in this area. And that there are, so we're seeing some, you know, some good progress and definitely some increase in interest. But I also think that trying to bring efforts together so that we have more individuals collaborating maybe on a more national front to understand what institutions are doing and be able to roll out a more comprehensive curriculum are some future next steps that could be awesome. And there definitely are barriers that still exist, right? So we need to think about those really consciously when it comes to self-advocacy moving forward. So what now? How do we kind of capitalize on this perceived increase in interest? And what can we do with it? So I want to turn it over to Priya, to my co-presenter, to tell you more about kind of current curricula, and then we also have some opportunities to get involved.
All right. Hi, everybody. Can y'all hear me okay? Thumbs up. Yeah. Okay, perfect. It's nice to see some familiar names. I would say faces, but I think it's mostly names, colleagues and friends in the audience. So it's good to see you guys today. For those who don't know me, my name is Priya Chandan. I'm the Vice President for Education for American Academy of Developmental Medicine and Dentistry. I'm also faculty at University of Louisville School of Medicine. And so thank you to AIRP for inviting me today to kind of talk about some of the things that I've been working on as part of Niche Medical. So I'm excited to kind of give you guys a rundown on that. But please, if you have questions, feel free to type them in the chat. I can sort of multitask. And so I put up kind of just this slide here to start a discussion for us on what is niche medical, understanding a little bit about what it is and what it is not. And so what we sort of think about is really important with the niche medical efforts, which is an initiative of AADMD, is the approach. So really, it's a community engaged scholarship sort of model. And so because of that, sometimes it looks a little bit different than I think folks are anticipating seeing when it comes to curriculum projects. It's really focused on action, on implementation, and also being community engaged. So every medical school as part of the effort has to have sort of, a PI or an internal champion person in the medical school who's faculty. We found that that's a best practice, as in it promotes sustainability. It also gets the medical school to kind of feel some ownership of this topic, to feel responsible for it, so that efforts sort of continue once the project is over. And the other requirement is to have community partners. And so we really look and vet as to if the school has community partners, how are they engaging them, kind of from the discussion we heard earlier, making sure that there's intentional inclusion and that self-advocates are involved kind of throughout the entire project in a meaningful way in leadership roles. And so that is kind of the basis of it. I think, guess a little bit of background, I would say that this is kind of the current phase of this effort. It's been sort of ongoing, I think, since about 2009, which again sort of speaks to curriculum being sort of a long game and not a short game, as I know everybody here today can relate to. But essentially, what we did is we thought about what can we do to support medical schools in implementation of IDD curriculum and sort of development as well as implementation. And what we realized is a lot of our champions aren't necessarily researchers, are full-time clinicians, are folks who maybe interface with people with IDD in a clinical context. And so they need support in some of the, I guess, aspects of medical education. So rigorous evaluation, things that I know everybody in this network is familiar with, but providing that support has been important. And so we decided to think of our medical schools sort of as a community partner as well when it comes to curriculum. And so rather than being prescriptive and saying, oftentimes when I say it's a medical education curriculum project, I get asked, well, where is the curriculum? Like, where is the curriculum in a box? And the whole point of this is that it's united by the evaluation, but as to what is taught, we expect that local context matters. We don't expect to see sort of the same formula for success at every school. We want each school to be responsive to their local partnerships and sort of use that flexibility depending on the local context so that they can take advantage of any and every opportunity to integrate curriculum content. And so we've seen in terms of how it's been implemented, as I say, when it comes to being successful, it can look a variety of ways. So we've seen successful implementation in the preclinical years as well as in the clinical years, have seen it in the context of standardized patients as well as OSCEs from a didactic sense. But if there is a didactic component, it's paired with sort of more of a community engaged approach as well. So if there's a didactic component, usually it's paired with a rotation or something experiential in nature. But we felt like that the approach sort of on the front end was really important in order to result in successful implementation sort of on the back end. So you might be thinking, well, what does that look like? So over the past, I guess since 2016, so 2016 through 2021, we had a partnership with Special Olympics International. And our initial goal was, can we get 12 medical schools, over 5 years, a year of planning, developing some tools. And then for the next 4 years, can we get 12 schools, about 3 a year, to do this? And we were pleasantly surprised because, and I think it speaks again to sort of the approach of this work. We were successful not only with 12, but were able to advocate for additional funding and got up to 18. And then we're able to support 2 additional schools that we didn't have funding available for, but we said, you know what, where there's a will, there's a way, and we supported them in seeking funding elsewhere. And so again, leveraging that, the collaborative, the sum is greater than each individual part. has been successful. And so there's 20 medical schools as part of that effort through those 5 years. And the reach as of 2022, so probably about a year ago, was a little over 5,000 medical students reached. And then as you all know, when it comes to implementation, there's kind of two pieces to that. So there's the research side or the evaluation side, and then the reach. And so as expected, the number of students that actually receive the content is going to be higher than the number that, say, fill out the survey, which is higher than, say, the analytic sample or who completed sort of pre and post evaluation. So for each of the schools, we supported them in an evaluation plan that, again, made sense for their project. And so utilized instruments developed by AADMD. So there was an attitude survey and a knowledge survey. And we're doing work on those now in terms of psychometric properties and validation and all of that good stuff. But what we were able to see from an implementation perspective is we were successful. And I think those of you who are in med ed know it is no small feat to get surveys completed. A lot of medical schools have rules on, you can only get evaluation from 25% of the class, rules like that to help promote or to reduce survey burden amongst the medical students, because certainly they do get a lot of surveys. And so we were really, I think, proud and excited. I think it's a testament to how much the schools sort of took ownership of this project, and certainly our learners, as we gave a shout out to earlier. They were a lot of the ones encouraging their peers and saying, this is important. This is why this matters. We're trying to make some moves in this area. So please fill it out. So we were able to end up with, and this is based off preliminary, we're a couple of schools data is rolled in a little bit after our initial timeline because of COVID. Again, medical education got thrown for a loop when that happened. But all in all, over 2,000 is the size of the sample, and then when you sort of pare it down to the analytic sample, it's right around 800 or so. And so a lot of rich data on the attitude survey side for us to take a look at and kind of think about how can we support schools moving forward. I think to nobody's surprise, high priority on the school side is evaluation tools that are shorter. And so we're hopeful that, we have good data. We have, our best effort at the time, which was 2016. Now we're sort of looking at it again with fresh eyes and thinking about what do we do with that to assist those kind of moving forward. And so speaking of moving forward, if you can change the slide, there is going to be an upcoming RFP. And so I will kind of show you where that's going to be available online on November 1st, so coming up. But these are kind of the 4 pillars as far as the work that's in progress now. So 1, we're always looking to build capacity in terms of partnerships. 2, supporting learners. So we're creating a RFP process and program for learners to be able to receive funds directly in the form of stipends to support them doing away rotations. So on the clinical side, once you're in your 3rd and 4th year-ish, every school is a little bit different in their timeline. But in the clinical years, you have the ability to do away rotations. And so for those who really want deeper experience in this, we're hoping to kind of help pair them and sort of help facilitate the process for them so that they can go get additional training. And so that's going to start January 2024. And then the medical school partner grants, those are ongoing. That is what's going to open up on November 1st. And then the next, so the 4th piece of this is kind of seeing what we can do to advance the literature. So what are sort of high priority things to help move the field forward? And for right now, we're working on sort of attitudes, survey validation, but other things to follow include connecting with different partners in the space and sort of figuring out what it is that needs to get done, how can we partner together, and kind of move things forward. So that's the big overview of what niche medical is. But I appreciate being able to join today. If you could go to the next slide, because this is timely, since we're about to open this up to additional medical school partners. And essentially, we've had some schools who are connected to a USED, some who aren't. And so it's an opportunity, I think, for us to kind of help to be a bridge, to help build bridges. Obviously, when we get applications, if they are connected to the network, we make sure that they sort of propose with their USED. If they're not connected, I make sure to kind of educate them on that. I think there's a lot of interest. As we spoke about earlier, there's a lot of new interest. So there's a lot of folks who are now interested in disability or IDD education that may not be familiar with the infrastructure and the resources that exist. So we see that as an important part of our role as well. So that's kind of the big overview I had for you. So I will kind of turn it back over now, but I'm certainly happy to answer more questions and have discussion after we conclude our slides.
Thank you, Priya. One other opportunity we wanted to share with you all is from AIRP specifically, and it's our upcoming, our next cohort for the Scholars Pilot and Feasibility Funding Program. And the next request for proposals is going to release early 2024, so probably late January, early February. And these are small amount of funds for pilot and feasibility funding and something related to medical school. They need to be related to autism and physical health and really advancing that area. And so something related that's medical education, medical or dental education related could be appropriate. There is a question in the chat that I want to make sure and read out. The question is, what would be some effective strategies from a policy standpoint to implement at the medical, dental, veterinary medicine schools? Maybe expand to local health departments? Priya, do you have any input on that?
Yeah, I think, and feel free to type in chat. If I'm understanding the question, effective strategies, you mean geared towards improving implementation? So I think some of the strategies we heard sort of loud and clear from some of the conversations at a national level kind of this year. I think a lot of folks were focusing in on the strategy is let's have this be required. And then that will promote sort of adoption, implementation, right? But what we heard in conversations with LCME, AAMC, and others is actually the way it tends to work is the opposite. So what they are looking for is to reach critical mass, and then it will be something that those organizations that have sort of the most leverage will adopt as, hey, this is something coming from us that you need to be implementing at your local institution. I've seen this play out in the equity space in regards to other curriculum efforts. So particularly with the anti-racism curriculum, it's not a requirement, but now it's become one of those positive peer pressure things that, if you're not doing it, that's a problem. And people are pretty vocal about that. And so I think disability education sort of has a chance for kind of the same strategy. And that's partially why we are trying to sort of present and connect everyone as part of niche medical, just so we can advocate a little bit more effectively and say, hey, this is happening. There's actually a lot of people that are successful in doing this and think it's important and know how to. So now's the time to kind of come up with something more formal. So that's kind of the big strategy there. I hope that got to sort of what you were hoping with the question, but then also in regards to local health departments, I think that there's overlap there, and I see that particularly with some schools. So in some cases, when it really depends on the network of the team at the school. And so I do have a couple schools where they are involved with their local health department, because the team that's doing this work is involved with the local health department in other projects in other ways. And so there's sort of cross-pollination there. But so I really think that another strategy is being really mindful, intentional of who's the team you're bringing together to kind of do this work. And that's what I've seen as effective, leading to implementation and unique partnerships as well.
Let us know if there's any additional questions related to that that we can try to help and answer. Two other questions in the chat. One is asking, do you know of any other development of medical curriculum for other groups such as PAs or NPs? And that's an interesting question. I also, taking it a step further, it recently came up about some sort of level of training for front office staff and patient-facing more administrative staff. We're working on an initiative here at UCLA to try to greatly increase inclusive disability training for primary care providers, and are working on rolling out a health system-wide initiative. And when I was meeting with one of the other groups recently who has done this on a different topic on LGBTQ plus health, one of the things that they brought up that they got a lot of requests for from the beginning when they created this health system-wide content was having more training for front office staff, which we had been focused on training, the primary care providers for this specific program. But I thought that that was something really valuable and that we needed to include and make sure that in varying levels of the process and the stages of individuals interacting with the clinic or interacting with medical care, trying to increase the amount of individuals that we can train. I'm not actually familiar with any specific nurse practitioner or PA like focused programs. Are you at all, Priya?
Yeah, I think so. There's been a couple. The beginning of this kind of these efforts was with an NP program, but it's been some time now. I will say that kind of we have sort of this 5-year plan. So the first year, which is 23 to 24, was kind of get back up and running, and then 24 to 25 is when we're sort of bringing on cohort 2 for the medical schools. But as part of that, we're also planning to have an RFP that just says, hey, if you have an idea, please suggest it. Because we're hoping that, all of the work and the development can sort of be utilized by other health professions too. And so the charge of niche medical is medical schools, just because that was sort of the focus. It's a partnership with Elevance Health, but we did write in with them to say, hey, I think we can all agree this is needed sort of throughout in other health professions as well. And so when the opportunity presents itself, we're planning to partner. So I do have a partnership developing right now with physical therapy, with PT, as well as with OT. So things to come, but just sort of in the beginning stages. What I'm hopeful of, because again, in thinking about strategy, it's nice when we can all sort of, again, positive peer pressure people into doing things by leaning on a collective. And so my hope is, and I've seen this gain a little bit of traction, is to say, okay, so here's what the med schools are doing. AADMD does a lot in the dental education space. And so we've used that strategy time and time again to say, the dental schools passed a requirement. Med schools, where are you? And so the same thing. So I'm hopeful that we can be sort of a common ground. I'm always happy to write letters of support for other groups to say, this has been successful here. This is not the only place this is needed. Hey, if somebody has the network and the ability to start it somewhere else, why don't we come together and do that? So I'm not intimately familiar, but that's my hope, is that we start to build those bridges and kind of all together, because as we all know, this is a health professions sort of more broadly issue. Certainly not just medical education, but sometimes strategically, if that's where you have to start, where they're listening, then start there and then grow.
That's a good point. Within our UC Lend training program, we have a nurse practitioner training track where we were able to become one of the site rotations for a psychiatric NP training program. So we have psych NPs that are with us for 6 months at a time, and they are going through similar content with our other Lend trainees, kind of broader public health perspective of disability, and then do a lot of intensive time with shadowing and then seeing patients within our interdisciplinary Lend clinic. And so I'm wondering if at some of the PA or NP schools that may also have Lend sites or other within, like the AUCD and related network. I think that may be a way that somebody could get involved with it in some way now from a training perspective. But I agree with Priya that we don't just need to train medical students or dental students, but also expanding that is really key. So I think that's a great question that you asked. And next question, I see that you included self-advocates. How are you ensuring that those who are profoundly affected, example given profound autism, are also having their needs included in the conversation? I can take this a little bit, Priya, and then you might have things to add as well. So when it came to the inclusive medical and dental school curriculum project that I was talking about in the beginning, we really wanted to make sure that we were able to include as many perspectives as possible in collecting the data, but then also in dissemination of our final results. We were targeting existing medical and dental schools who had some level of disability curriculum. And then reaching out to individuals that had been involved, individuals with lived experience or self-advocates who had been involved in the creation of that curriculum. So our sample, right, was kind of limited to those who have been involved in some way. But also throughout that process, as we were doing, focus groups and encouraging individuals, those who preferred to, or that was their, main form of communication, being able to type in the chat. It also brought up some internal conversations that I found really interesting, that it seems to me the more inclusive of style of research that you're trying to do, it also does make benefits and things a little bit easier on the data collection and data analysis side, right? So I think that was kind of a pleasant benefit as we were really utilizing the chat and different forms of communication during the focus groups. And we included parents. That's one of the big reasons why we included parents, to be able to have more of the perspective of those individuals who have a high level of support need in a variety of different areas, because I think that it can be helpful with kind of the current voices we have at the table, but that is a group that's not often brought to the table. So then the last thing I wanted to say about that is that I think that's one of the areas that can be improved upon in the future greatly, because quite a few of the individuals we're talking about, the self-advocates involved in the process, we're talking about giving lectures and, providing content in that way. And so I think that being able to include a more diverse group of individuals would have a much greater impact on the medical students. And also then how to do that in a really meaningful and not ableist way, I think is an important part of the conversation that from internal conversations I've heard at others who are creating medical school curriculum, that it's something that people are talking about and trying to figure out exactly how to do. So I think some more of this kind of universal guidance or, rolling out more information for those who are trying to increase this type of curriculum, I think would be beneficial. Priya, do you have anything to add?
Yeah, no, I definitely agree with those comments. And I think sort of from my perspective, I think like the paradigm in medical education has been shifting a little bit, and particularly since the pandemic. No surprise, I think you can see how sort of those who are on the front lines and we're trying to also educate trainees during it realize some things. And I think one of the things that they realize is that I'm never going to be able to teach you everything. What I need to do, particularly in the early part of medical school, is teach you how to think how to unlearn some things that maybe you learned prior to getting to school. And so I think a lot of the preclinical coursework in particular is from that lens. And so when it comes to ensuring that, different folks' needs are included, that we're mindful of that, we're really focusing on, again, kind of rethinking medical education a bit. How do I teach you so that you're able to determine what is the need, what is this person presenting with, how can you support them for every patient you see? Giving examples, certainly, and the self-advocates, I think, are what the students remember most. And so being really intentional and sort of who is, doing a lot of the teaching activity. But then I think too, constantly we're sort of hammering to the students to say, please remember, if you've met one person, right, you've met one person. And so helping them realize that that is an important part of it too, is that your job, at least in med school, as we say, is the patient in front of you. And so please don't, you're trying to guard against the harmful part of this, where if you do an activity and you introduce a particular person, that you don't want them making that clinical reasoning error where they say, that is what everyone with this particular condition looks like, and they all have the same needs. And so that's definitely, I think, a learning point that I'm seeing a lot of. So not a specific example from a specific school, but if that helps kind of just as a kind of, again, the approach, the sort of overarching lens that I think is being used a lot is that. And I think the benefit of that is, again, we're seeing a lot of really unique collaborations. We're seeing a lot of helping students with the scaffolding so that they kind of see education efforts in different spaces. So whether it's LGBTQ health, whether it's anti-racism curriculum, whether it's disability curriculum, those things are not, quote, as I call it, quote, special topics, nor are they each separate special topics. People can exist with any and all of those identities. And so your job is to understand the patient in front of you and what are their needs. So again, I think a lot of effort is being put into helping people think through how they think.
This might also be a good time to give a plug for the upcoming AUCD conference. And we have a panel on this topic on inclusive medical school disability curriculum. And I was recently looking at the slides for it, and one of the co-presenters had some really great recommendations for providers. And one of the things that I saw on that list that was also just reiterated in a recent talk from UCLA Speech to our LEN trainees is assume competence. Always assume competence in the individual, that you're talking to, and not making sure that you're not removing the power from them and their ability to advocate for themselves, and that, being able to provide information. So that kind of stuck with me. I think those are all the questions, unless Nellie, tell me if there's more questions that I just can't see. If others have questions, please feel free to drop them in the chat or to speak up. I have a question for Priya. I was really excited when I first learned about niche medical because you all are doing some really cool work. And also the kind of the level of support that is, around the projects and the attitude survey and things like that. What types of projects would you say, I'm trying to encourage others to be for the upcoming niche medical RFP, what types of projects would you say are a good fit for that RFP?
Yeah, so I think what we tried to do, again, with being sort of action-oriented, focusing on implementation, what we know is that's the next step is going to look different in every place. And so some of our schools have a robust, longitudinal curriculum. Maybe they're looking at, if we were able to build a partnership with a new community partner, it would allow us to expand in these following ways. Other schools, I have, one in particular that's literally like, there's nothing. I'm just the one person that happens to care because I have a sibling. And so anything is a, like if we can make a step in the right direction, certainly we're not going to have the entire curriculum built in one day, overnight, in 1 year even. But we want to start here. And if you look at the RFP, we put at the bottom, we said, pro tip, look at the old application and the new one is going to look similar. And what it asks to do, because again, we also are trying to make this accessible. So we don't want this to be only those who have a heavy research NIH type background, clinicians. Sometimes clinicians are often very, very close to our learners, and maybe have limited time in between documentation and peers to peers and all sorts of things. And so what it asks for and what is competitive is first describe what does it look like at your school, current state, and then describe to me what contribution you're hoping that this funding could help with. And so I think what I've seen be effective in terms of competitive is there's questions in there about sustainability, community partners, thoughtful, sort of, again, thinking about who is part of the team and why, and how are you amplifying and elevating self-advocates. And then what cool collaborations might you be able to come up with that maybe are new? Maybe you know somebody in the PA school or the NP school and you're thinking, why don't we do some things together? Maybe you work with colleagues in the LGBTQ health space. Maybe you work on anti-racism curriculum closely with HBCUs. I don't know. But all of those things, we're seeing way more of that. And that truly, I think, is what makes for competitive projects. And importantly, from an implementation perspective, right, we learn new things as people try new things. And so the more that, those who are funded are taking a different approach, a different direction, that's what we want to see. We don't want it to be, every project, like, here's the formula for like what we're looking for. No, the more I think creative, innovative things are, the better. There is a lot that has to get done. And so leverage what your local context, your strengths are, and have that match what you're proposing.
Oof, there is a lot that needs to get done. I agree with that statement very much, Priya. Here at UCLA, Juliana Rava from our team has really been spearheading some of the improvements and disability-related content that we have done for the medical students. And one of the really fun things was partnering, as you suggested, Priya, with the LGBTQ plus group. So we do some base camp activities. So that's before med school actually starts. We do some base camp activities together. And go through some cases and with small groups of the medical students, having a facilitator from the disability space and one from LGBTQ plus space. And they are so fun to do. I think this was maybe our 3rd year doing it. And it is such a blast to do, and walking through these cases and the intersectionality, and really having the medical students think about them, not just as like, okay, we're talking only about disability, but like, okay, we're talking about a human. So let's understand more about the different things that we need to consider. I see that Nelly is on camera, so I'm going to switch to this slide, as I assume I should.
Perfect. Thank you, Keisha. I was just going to throw a quick survey up in the chat, just to give some time if anyone else is formulating any questions in their mind for last minute questions before we all hop off. But if you have any feedback or suggestions for future webinars, that's there. Otherwise, I would like to thank both of you for today. It was a wonderful presentation. We had some great questions, and we had a great turnout. So I thank everyone for showing up today. It was wonderful. So are there any last minute questions before we all log off? Maybe I'll give anyone an opportunity to say anything. Oh, someone's raising their hand.
Hi, Rosalind, go ahead.
I think your mute should be off if you want to ask a question.
Hi. First of all, awesome presentation. Thank you so much for sharing this. I guess I'm wondering, is there anything that really surprised you coming from kind of a public health standpoint and going towards med school or a heavier medical program?
Was there anything surprising within like the current curriculums, or help me understand a little bit more?
Oh, the current curriculums and also like the reactions. I mean, are there just some reactions that you get that kind of flabbergast you or kind of make you sit up and take notice, like, oh, I didn't even know that was a thing. Like, is that real? Have you had any of those like moments that have kind of, you go in there thinking that medical students are going to need one sort of education or one sort of, standpoint, and then someone says something or has a certain attitude that just completely flips it on its head? Have you had very many of those, and can you talk about that a little bit?
I understand what you're saying. Thank you very much for providing more clarity. There have been a few things. This is related. When we first started doing some of the redoing some of the base camp curriculum, we were looking at some of the much older material. So there were surprisingly / not surprisingly some things that had been previously taught, when it came to disability curriculum, that weren't, that we made some great changes to. I will say there was lots of room for improvement, as I think there still is, right?
Right.
But also, when we are doing the sessions with the medical students talking about, LGBTQ plus health and then disability related health, one of the cases we present is a really interesting case that is involving like reproduction in an adult patient. And some years, it's interesting how long it takes for me to get one of the medical students to call out that there's an assumption that they are heterosexual, that they're having penetrative intercourse with a partner who has the capability or possibility of becoming pregnant. And that's a lot of assumptions all along the way, right? But when we first started doing it, I assumed, I work within a neurodevelopmental clinic, UC Lend, and also our gender health clinic here at UCLA. So I obviously have many biases, but I thought that people would be able to call that out quicker. And so I think maybe one year I think this year, actually, the medical students got there a lot quicker than previous years. And it could just be the group, obviously, right? Because these are small groups of medical students. But that was something that was really surprising to me, that I was like, oh, we need to do a lot more with just checking your own biases, thinking about the human who is coming in the door, and really understanding more from them and not having as many assumptions, when they come in. Priya, what you said, I think was great, that you repeated it 2 or 3 times. So I think it must be a mantra that you use within clinical care of like, think about the patient in front of you, right? I don't know if you have, go ahead.
Oh, yeah. I guess I'll share one last thing just because it's nice to like end on like something positive. So sometimes unexpected things you kind of are like, oh no, in a negative way. So I'll share an unexpected positive. So working with pre-med, so students before even getting into medical school, and I had given them, they were helping sort of look at some documentation, and they were kind of going through it. And we have quite a bit, sort of going through like the history, the 2002 Surgeon General report, and how it was, MR was used there, but now we, all of that. So there's quite a little bit of content that we do, kind of historical context, sort of explaining that. And so I just assumed, and I lost track of time, I guess, that, people would know what I'm talking about with that. But then the pre-meds, so again, these are folks who are not in med school yet, but are in undergrad. A couple of them came to me separate times and they said, what's this abbreviation, MR? And so then I would say it and I would explain it. And they're like, oh, okay. And I'm like, I mean, you've not heard that. And they're like, no. And they're like, why are you tearing up about it? And I'm like, never mind, it's fine. Just keep going. But so there's little things I think along the way that have been really encouraging to see coming from the learners, that like, day to day, sometimes I think in this type of work, it feels like things are so slow to change and things aren't changing. But it's nice still getting to be connected to the learners because I see little hints of things. And as I get to watch the cycle of rage unfold. So I'll say something casual about from when I was in training, and learners below me will be like, "What? How is that a thing? Like, how dare?" And I'm like, "No, that was actually an improvement about, but I'm happy that you think that's no longer acceptable." And that's kind of what I've been seeing with this is that, some of the things like, and they'll say, "How could that be?" Or "Can you believe that this?" And I'm like, these are all positive signs that that things are changing. So
Thank you. Thank you so much.
Of course, thank you for asking the question. The cycle of rage is going to make me giggle for the rest of the day, Priya. And I do agree. It is great hearing, especially from the learners. Rachel Parks is a MD PhD student here at UCLA who worked on the WITH Foundation project, and she's phenomenal from having her as from her research experience, but then also from her own experience being a medical student and trying to find more, disability content that can be provided. Thank you very much, everyone, for letting us be here and hearing more about things that Priya and I find super interesting and would love to talk with anybody about at any point in time. I hope we gave you some action items with the upcoming RFP from Niche Medical, the forthcoming RFP Scholars. ARP Scholars RFP that will be coming out, and then also a medical education panel that will be happening at AUCD in just a few short weeks.
Thank you, Keisha. Just a reminder too, to register for our December webinar. Thank you again for joining. This webinar has also been recorded and will be archived on our ARP website and will be put up on the YouTube channel. So if there's nothing else, then I hope everyone has a great day.
Thank you.